Well, welcome to our Grand Rounds East conference room. I am pleased that all of you made it here, and I apologize for the last minute notice in terms of the location. We just found out about it this morning. So, but it's a testament to your interest in Grand Rounds that you got here and that we have such a full audience, and I am very appreciative of that. I want to introduce to you Cecile Rose, who is a longtime friend and colleague of mine. Cecile is a professor of medicine and also a professor of medicine in environmental health or environmental and occupational health, as well as in the pulmonary division. She received her BA degree from Northwestern and received her MD degree from the University of Illinois. She subsequently did her residency training and also her fellowship at Medical College of Virginia, and then went to the NIH to study lung biology and worked in the NHLBI. She, I think, temporarily then went back to Medical College of Virginia as a young faculty member, and then in 1988 she was recruited here to the University of Colorado. I first met Cecile, I think, in 1990 when we were on a study section together, and I was really impressed with her ability to look at science broadly and to think about the impact that the research and the investigator was potentially making in terms of their scientific contributions. And she and I have stayed in touch with each other over the years since 1990. Cecile has primarily been interested in environmental lung disease, has focused on co-workers pneumoconiosis and also combined exposures between allergen and endotoxin, a very interesting area of research. And as you can see, has also been interested in lung disease in those deployed to the Middle East. She is also focused in a way that is exemplary, I think, in terms of training and education of individuals, whether they be medical students, house staff, or fellows, in terms of gaining skills in occupational and environmental medicine and also gaining research skills in this area. So please join me in welcoming Cecile to the podium.
All right, thanks. And do you have a pointer? Is that a pointer? Yep. Yep, got it. Well, thanks very much, David, for that very kind introduction. We do go back a long ways. And thank you all for coming and finding your way here. And I'd like to thank Silpa Kref for getting me here, too, because I had no idea where I was going. So I'm going to talk today about lung disease from post-9/11 military deployment. I have a few disclosures. We have Department of Defense grant funding, have had that for about the past 4 years, and recently in October of 2016 got another DoD grant. We also have funding from the Sergeant Sullivan Center, and we appreciate all that. So I was asked to begin with a case. This is a 29-year-old soldier who came to our clinic at National Jewish Health with symptoms of exertional and disabling shortness of breath and dry cough. He had no history of respiratory disease. He was a never smoker, and he had a pre-military deployment Army 2-mile run time of 14 minutes. So in the Army, people are required to pass the physical readiness test. They have to meet certain criteria in terms of their 2-mile run time. His was fairly decent. And he deployed to Iraq to Joint Base Balad for about a year, 2005 to 2006, where he was exposed to burning waste and to sandstorms. And after his deployment, he was unable to complete the 2-mile run time due to his disabling shortness of breath, which placed him at risk in terms of job loss and being medically boarded out of the military, which was not something he wanted to have happen. His pulmonary function test showed that he had normal spirometry. On complete PFTs, he had an elevated residual volume, which is indicative of air trapping or hyperinflation. Normal RV is 120% or less, and his was 169%. And his diffusion capacity for carbon monoxide was within the normal limit at 84%. We did a methacholine challenge test on him to see if he had asthma, and he had very borderline mild airways hyperresponsiveness based on his methacholine challenge. And he underwent cardiopulmonary exercise testing, and the only abnormality on that was that he had a reduced VO2 max. He did not have significant gas exchange, ventilatory, or cardiac abnormalities. So in the face of fairly underwhelming, nonspecific pulmonary function test results, he underwent some imaging, and he had a normal chest x-ray. But his high-resolution CT scan, and you see on the top is the inspiratory image, and on the bottom is the expiratory image, but his high-resolution CT scan showed areas of mosaic air trapping, which I think you can probably appreciate are areas of lucency, and some central lobular nodularity, and as well a tree and bud pattern to some of these central lobular nodules. So he didn't know what he had, and he underwent a surgical lung biopsy, and his biopsy showed that he actually had constrictive bronchiolitis and emphysema, and that is present here. As you can see, there's areas of fibrosis around this bronchiole and obliteration in the bronchiole, along with areas of hyperinflation and probable emphysema with clubbing of the ends of the alveoli that have been disrupted, which is suggestive for hyperinflation. So what I'm going to talk about today are the inhalational exposures and the spectrum of deployment-related lung diseases. We'll talk about our approach to clinical evaluation and diagnosis, and I want to share with you some of the results of our research study on the lung histology and mineralogy of deployment lung. Then I'll update you in terms of what our kind of forward-thinking research is focused on, including both the search for non-invasive markers and the better understanding of the pathogenesis of deployment-related lung disease. So you may know that over the past 15 years, nearly 3 million Americans have deployed to Iraq and Afghanistan. And there are some euphemistic names for some of these military operations. As you can see here, the most well-known ones are Operation Iraqi Freedom between 2003 and 2009, and Operation Enduring Freedom in Afghanistan between 2001 and 2014. The inhalational exposures in Southwest Asia are complex, and they're actually poorly understood and poorly described. Probably the two most important ones from our perspective are exposures to desert dust particulate matter, which you can see here, as well as to burn pit emissions. And burn pits are large open areas that are used to burn all kinds of waste that are generated as part of the military mission when people are deployed. And you can see here this man is putting waste into this very large open burn pit. Some of them are very small, some of them are the size of a football field. And they typically sustain the combustion by putting in jet fuel and just letting things smolder and burn. Other things that people are exposed to, of course, are things like industrial fires and pollutants from local industries, cigarette smoke, both direct and secondhand smoke. There's a lot of reporting of vehicular exhaust, diesel exhaust exposure, and combat dust. Temperature and humidity extremes, as you might expect in these very austere environments, as well as some exposures, particularly indoors in these sometimes air-conditioned units, where there may be allergens and microbial agents, including pests, that can affect indoor environments. And then there are job-specific exposures, including to vapors, dust, gases, and fumes, what is referred to in the occupational medicine world as BDGF. And this is another picture of smoke from a burn pit in Iraq. And here is another picture of a sandstorm rolling over an Iraq base camp. And these are pictures of combat dust. So you can see that really there is a lot of exposure, and it's very hard to quantify or characterize the individual exposures that deployers may experience when they're in Iraq and Afghanistan and other parts of Southwest Asia. So once these military endeavors got underway, the military did some sampling to try to understand what people might be exposed to. And in 2009, a paper was published from the Enhanced Particulate Matter Surveillance Program, in which they looked at 15 locations in Southwest Asia, including 6 in Iran and 2 in Afghanistan. The military industrial hygienists obtained over 3,000 filter samples where they looked at total suspended particulate, PM10, which is particulate matter of 10 microns, and PM2.5, which is the respirable fraction of particulate matter, the part of the inhalant that gets down deep into the lung. And what this testing showed is that all of the sites, all 15 locations, exceeded the military exposure guideline of 15 micrograms per cubic meter for PM2.5, which, by the way, is higher than what the Occupational Safety and Health Administration allows. And they found in that respirable fraction of dust that there were 3 main pollutants. One was geological dust, the second was smoke from burn pits, and then the third was this kind of profile of heavy metals that included aluminum, cadmium, and lead. And in around 2004, so about 3 years after OEF started in Afghanistan and about a year after OIF started in Iraq, reports of respiratory conditions started to emerge in the published medical literature. And in one of those was this very interesting kind of case series of deployers who developed really severe acute eosinophilic pneumonia, including several fatalities. They did a rather in-depth investigation, did not understand what was driving these episodes of acute eosinophilic pneumonia. And then at around the same time, more broad-based epidemiologic studies started to show that deployers were coming back from Iraq and Afghanistan with increased rates of respiratory symptoms, particularly those who were in the Army and who were land-based. As more reports came out, people started to understand that there may have been an increased risk for allergic rhinitis or allergies in certain deployment settings, for new onset asthma or aggravation of asthma. And then in 2011, a very important sentinel paper came out from investigators at Vanderbilt that described a risk for constrictive bronchiolitis. And this was published in the New England Journal of Medicine. And what the pulmonologists at Vanderbilt found is that they were being referred patients from Fort Campbell, from the 101st Airborne, who had undergone some medical evaluation for disabling shortness of breath and for which no one understood what was going on. So they sent them to the pulmonary folks at Vanderbilt. And what the Vanderbilt paper describes is that there were 80 soldiers with unexplained exertional shortness of breath and decreased exercise tolerance, of whom 49 underwent surgical lung biopsy, and of which those 49 undergoing biopsy, 38 had constrictive bronchiolitis. The median age in this group of deployers was 33 years. 66% of them were never smokers, and all of them underwent fairly complete conventional pulmonary evaluation and had either normal or very non-specifically abnormal pulmonary function tests and high-resolution CT scans. So our occupational lung disease program was also starting to get phone calls from deployers who were coming back and from pulmonologists, very good pulmonologists, who had evaluated them for unexplained shortness of breath and who did not know what was going on. And so what we did was pull together a working group on post-deployment lung disease that met for the first time in February 2010 at National Jewish Health. It was a multidisciplinary group of scientists, pulmonologists, occupational medicine folks, epidemiologists, toxicologists, industrial hygienists, geologists, and both MDs and PhDs. And the people attending the working group were both from the military, including folks from the VA here, York Miller, Bob Keith, Carol Welsh, and also from different academic programs. And the idea there was to review the current data and knowledge gaps, discuss a coordinated approach to clinical and research efforts, and to come up with consensus recommendations for medical surveillance, referral of people who were symptomatic, and then an approach to diagnosis. And in 2012, the working group published the recommended approach to referral, surveillance, and medical diagnosis. And what we recommended is that people should undergo comprehensive occupational and medical history, physical examination, complete pulmonary function testing, methacholine challenge in certain circumstances where there was a high clinical index of suspicion for possible asthma, chest high-resolution CT scanning, both prone and supine positioning with expiratory imaging to enhance the finding of mosaic attenuation, metabolic exercise testing for people who had exertional shortness of breath, and that people should be considered for surgical lung biopsy if there was a clinical concern for constrictive bronchiolitis. And we did not make that recommendation easily, nor was it an easy conversation to have, because most of you know that surgical lung biopsy is an invasive procedure. And so we thought through over time what the indications for surgical lung biopsy should be in the setting of this rather poorly described and not very well understood kind of circumstance in terms of distal deployment lung disease. And what we decided is that people should be considered for surgical lung biopsy if they had unexplained and disabling chest symptoms, if there was a lack of diagnostic clarity, if they had been treated empirically and that had been unsuccessful. And by empiric therapy, I'm talking about sort of the usual things that we do for lung disease, inhaled therapy, maybe a course of oral steroids, treatment for comorbid conditions that may cause cough, like gastroesophageal reflux disease or rhinosinusitis. And that most importantly, the patient who is referred for surgical lung biopsy needs to understand that the procedure is invasive, it's painful, it's potentially risky, and that the findings of constrictive bronchiolitis or other abnormalities may not inform their therapy particularly, affect their symptoms, or necessarily change their outcome. At the same time that we were working our way through kind of a standardized approach to evaluating people, we also applied for funding to develop what was called a morphometric approach to the quantification of small airways disease and particulate matter exposure profiles in the lung biopsies of deployers. So we really wanted to look carefully at the surgical lung biopsies and really understand whether they showed constrictive bronchiolitis or what they showed. And we shortened that very wordy title to the R2D2 study, the respiratory disease related to deployment study. And the specific aims were to characterize the histologic abnormalities in lung tissue samples from deployers compared to normal lung tissue samples and also to autoimmune bronchiolitis samples. To develop a more standardized pathologic scoring system, the pathologist at Vanderbilt actually had taken some criticism because there was always this concern that perhaps they had overcalled the abnormalities. And so the Department of Defense was interested in having a more standardized and independent approach to looking at the histology. And then the third thing we did was we built a collaboration with scientists at the U.S. Geological Survey to use techniques of scanning electron microscopy and laser ablation mass spectrometry to analyze the mineral, fiber, and particulate matter components in the lung tissue samples of the deployers. And our hypothesis was that maybe we could find a marker or a signature or a fingerprint in the lung tissue itself of what the relevant or etiologically relevant exposure might be. So we got surgical lung biopsy tissue samples from 50 deployers, both from Vanderbilt and National Jewish. We had 20 lung explants from people known to not have lung disease. We had 19 positive controls for the Lung Tissue Research Consortium for autoimmune bronchiolitis. And we had the opportunity to characterize all the different patients whose samples we had access to in terms of their smoking history and their medical histories. So after obtaining the samples, we sent the samples all to Vanderbilt so that they could do H&E and pentachrome staining so that there would be no kind of bias related to where the tissue staining was done. And then the samples were scanned into the Aperio microscopy system and disseminated to 4 study pathologists, all from different institutions, none of whom had read these before. And the pathologists worked with us to develop a scoring system so that they would analyze the findings systematically. And then we worked with a biostatistician, Matt Strand, to try to understand what the findings showed. And what I want to share with you here, it's a little bit of a busy slide, is that this is the demographic and smoking characteristics for the deployers, the normals, and the autoimmune bronchiolitis control cases. And what you can see here is that in terms of the deployers compared to the normals, that there were no differences in terms of gender, age, or smoking between these 2 groups. Not surprisingly, the autoimmune bronchiolitis controls were significantly more likely to be female because women are more likely to develop autoimmune lung disease, and they were also older, but they were no different in terms of their smoking history compared to the deployers. What this shows is the results of our multivariable logistic regression analyses that showed the diagnostic findings in the deployers compared to the normal controls, that's this group, and the deployers compared to the autoimmune bronchiolitis controls. And what you can see here, this is the p-values and this is the odds ratios, is that the deployers were significantly more likely to have respiratory bronchiolitis, constrictive or obliterative bronchiolitis, or emphysema compared to the normal controls, and that was controlling for smoking and age. We also found that respiratory bronchiolitis was significantly more likely in the deployers compared to the autoimmune bronchiolitis cases, but that cellular bronchiolitis, as you would expect, would be more likely to be found in the autoimmune bronchiolitis cases. It was not statistically significant, but it was of great interest to me in particular, because I have an interest in granulomatous lung diseases, is that the deployers had an increased odds ratio for what the pathologists independently scored as hypersensitivity pneumonitis compared to both the positive controls and to the normal or negative controls. So to summarize, in terms of our lung biopsy findings, the lung biopsies of deployers were statistically significantly more likely to have findings of respiratory and constrictive or obliterative bronchiolitis compared to the normals. And controlling for age and smoking, the deployers were significantly more likely than normals to have emphysema. So we also looked at the lung mineralogy again, using the techniques that were available from our collaborators at the U.S. Geological Survey. And we took tissue biopsies from the 3 groups, deployers, normals, and autoimmune bronchiolitis controls, matched for age and smoking, and looked at 11 samples from each group using field emission scanning electron microscopy and laser ablation inductively coupled plasma mass spectroscopy. And in that, there were 60 total, 20 in each group, and the scientists, of course, were blinded to the status of the samples. So what we did was we did serial sectioning on the biopsies. We had the pathologists look at areas of high particulate matter or pathological abnormalities in normal areas, and then the scientists at USGS used the field emission scanning electron microscopy to characterize particle mineralogy, size, shape, chemical composition, and location, and also used the laser ablation ICP-MS to identify, quantify, and map trace metal distribution in the lung tissue. And essentially what they did, and you can kind of see this here, is that they probed these lung tissue areas to try to figure out what was in those particles. And so this is silicon dioxide, titanium dioxide, kaolinite. And it was interesting because, of course, the language of exposure for USGS is an earth-based language of exposure. And so I had to learn a lot about geology to understand things like kaolinite. But the folks at USGS then developed these modal abundances, these kind of individual maps of what was contained in the particles in the lung tissue. And so this busy slide is here to show you, these are the autoimmune bronchiolitis group, the deployed group, and the negative or non-affected control group. And what you can see here by looking at all these different modal abundance maps is that there was extraordinary variability. So our hope, and what the colors are here to show you is, how this person had an awful lot of clay, and this shows you their smoking status. And so, our hypothesis might be, for example, that deployers would have a lot more silica because they were in these desert sandstorms, or that perhaps, they might have a lot more metals or titanium that may be contained in particular metals that are used there. And in fact, we didn't see anything that was particularly helpful, although they really did beautiful work in terms of coming up with these modal abundance maps. And so what the scientists at USGS described is that there was marked variability in the particle types and the amounts between individuals. And we found no correlation between particle type or abundance and deployer status. Now, remember, we only have 11 people in each different group, and so our numbers were fairly small. But this was extremely labor-intensive work, and we were figuring out as we went how to develop these modal abundance maps. The anatomic location of the particles was similar among the groups. The particles occurred mostly as rounded clusters in the collagen matrix of the lung, and we found that the clusters could be monomineralic. They were really one mineral there and nothing else, or composed of many different particle types. And we, again, had sort of a hope that we categorize the different kinds of particles as either more likely to be geogenic, that would be based from geological exposures like sandstorms, or anthropogenic, which would be more likely coming from human-sourced exposures. But we didn't really see that this sort of separated in terms of our hypotheses at the outset. Now, what we did find using the LAIC PMS technique was that the detection frequency and the intensity of silica, aluminum, magnesium, and vanadium was higher in deployers than controls, which was interesting. But again, as I mentioned, the geogenic and the anthropogenic modal abundances and distributions did not distinguish the deployers from the controls. So we found this very interesting. We were particularly intrigued by what was happening in terms of the histology of the lung, both in the deployers who we were seeing here in Denver and what they described in Tennessee at Vanderbilt. And so we were at the same time kind of putting together this clinical center for deployment lung disease at National Jewish Health. And we used the approach that had been published by the working group to understand how we might think about evaluating deployers who were symptomatic. All of our deployers underwent a standardized questionnaire that we developed to try to really characterize their, this is pages and pages of information on how often you're exposed to sandstorms and desert dust and VDGF and all kinds of things. They also underwent a 90-minute history and physical exam. We reviewed their outside records and images. We did pulmonary function testing, high-resolution CT scanning, and cardiopulmonary exercise testing because most of them had cough and shortness of breath. And then, of course, we took care of them as doctors do, looking for other things that they might need to undergo for diagnostic clarity. We did not want to send people or suggest that people even consider VATS lung biopsies if they had asthma, or if they had vocal cord dysfunction, or if they had, cardiac disease or gastroesophageal reflux disease or whatever. So, we would tailor the diagnostic approach based on the symptoms. And I'm going to briefly summarize the characteristics of the 124 cases that we have seen so far. It may be a few more now. 88% are male, not a surprise. The mean age is 38 years. 50%, half of them are never smokers. Most were not current smokers. And not surprisingly, the service branch was 69% from the Army and Marines. 59% had deployed to Iraq only, 22% to Afghanistan only, and 19% reported having been exposed to or deployed to both Iraq and Afghanistan. And the mean deployment duration was almost 20 months, with a range of 30 to 57 months. And the mean deployment frequency was almost twice, but some people had been deployed multiple times. terms of the reported exposures, 64% reported daily burn pit exposure. That is daily burn pit exposure. And we asked some questions around proximity to the burn pit, which I didn't have time to go into. But, you know, again, we're really trying to understand what may be driving risk in terms of exposure. And we asked about weekly or biweekly sandstorms. 70% reported those. 83% had dyspnea, 77% cough, and 73% had wheezing or chest tightness. And, you know, again, of interest is how long does it take to get this disabling shortness of breath or cough? And we were a little surprised that the mean symptom latency was about 2.8 years. A lot of people report having had symptoms when they were in theater. But one of the things that we also realized is that when people report getting symptoms on their way home or just as they're getting ready to come home, that it delays their coming home. And so people are in some ways disincented to report having symptoms when they're in Southwest Asia, in Iraq or Afghanistan, because it may delay them coming home. The pulmonary function test findings were kind of you know, not as interesting as you might think. Only 23% had an obstructive pattern. Only 21% had a diffusion capacity that was below 80% of predicted. There were 41% who had an elevated residual volume. At the time, we were using 140% as the cutoff for elevated RV. 36% had a positive methacholine. 64% had reduced exercise tolerance based on VO2 max. But without helpful, for the most part, you know, there were a few, but without particularly helpful findings of gas exchange abnormalities or, you know, cardiac or ventilatory abnormalities. And the chest CT scans were typically normal or nonspecific. So to just kind of summarize them, the spectrum of deployment-related respiratory disorders that we have seen in this group of over 100 deployers, we do see rhinosinusitis. We see vocal cord dysfunction in some. We found new onset asthma or aggravation of pre-existing asthma in about a third. And there are some who develop bronchiolitis and or interstitial lung disease. And so I wanted to show you the three histologic patterns of lung disease that we have found. And they are emphysema, constrictive bronchiolitis, and granulomatous pneumonitis, as we found when we looked at the deployers more systematically with the panel of pathologists. And the reason these don't all add up is that as with the first patient I showed you, and this is actually his biopsy right here, some people have constrictive bronchiolitis and they have emphysema. So we found that emphysema or hyperinflation was present in 65%. 15 of these 24 were never smokers. We found 51% with bronchiolitis and 49% with granulomatous pneumonitis. And when we looked at differences based on smoking status, we did not find that there was really any difference between never smokers and ever or current smokers in terms of the risk for these conditions. So I think I have 40 minutes. I will now just tell you a little bit about what we then did in terms of trying to put together, you know, another step forward in understanding the pathogenesis of this condition. We applied for and received Department of Defense funding, and the acronym for our research group is GLIDE, the Group on Lung Injury from Deployment. And so we are now called, we've moved from R2D2 to the GLIDE study. There are 4 major projects. And I want to just end by reflecting on a couple of the specific aims. One is under my project, which involves exploration of non-invasive markers of deployment lung injury. And then Greg Downey, who's the principal investigator on this grant, is really leading the effort to characterize the lung injury mechanisms and pathogenesis. So one of the big things was that we really don't like sending people for VATS lung biopsies, especially when we don't have much to offer them in terms of therapy. We have certainly learned a great deal from looking at those biopsies systematically, But given costs and risks, we felt like there was a critical need for non-invasive markers of deployment lung disease. And we know that spirometry has very poor sensitivity in the detection of small airways diseases like bronchiolitis. So my colleague, Dr. Silpa Kreft, became interested, along with Dr. Richard Meehan, in looking at lung clearance index testing as a non-invasive marker of small airways disease in deployers, because it has been shown to be a promising tool for the early detection of small airways disease in patients with cystic fibrosis. And so Kreft et al. Examined LCI scores in 28 symptomatic deployers compared to 24 controls. And what you'll see here is that when you don't adjust for age, smoking, and BMI, that there was actually a fairly significant difference between the controls and the deployers in terms of their LCI scores. So the higher the score, the more likely the patient is to have small airways disease, because this is a lung washout technique and it just takes them longer to wash out. However, adjusting mainly for BMI, we found that that this kind of lost statistical significance. And yet it's a very small group of people that had been done so far. So we are moving forward to look at LCI and its role in the early detection of small airways disease in the deployer population. And then our colleagues in the imaging department, Dr. David Lynch, Steve Humphreys, and Caleb Richards, have also been frustrated in terms of the approach to understanding the CT abnormalities, because depending on who the radiologist is, they may find bronchial wall thickening, or they may see a little mosaic hyperattenuation, or there's a lot of variability from reader to reader, and no standardized way of really looking at this. And so again, this just shows you the central lobular nodularity, which is circled here, that reflects small airways thickening, and then areas of bronchial wall thickening and expiratory gas trapping that are more obvious on an expiratory image. But, a lot of times the CT scans are normal. And so David Lynch has now taken the techniques of quantitative CT evaluation that they're using in the COPD gene study, and is going to be doing a textural analysis of central lobular nodularity. And I don't know if this shows up very well, but in the purple, these are areas of central lobular nodules. In the red, these are some more normal or emphysematous areas. And so what Steve Humphreys and David and the folks in radiology are doing are classifying these regions of interest, and then using this textural analysis to develop an algorithm to really figure out, is there central lobular nodularity or emphysema there or not? And this is just their data from the COPD gene study that shows that, in people who are current smokers, that, you're more likely to see findings of respiratory bronchiolitis and emphysema. So we're hoping that this combination of textural analysis and quantitative imaging on the CT scan, in combination with the LCI and perhaps some other biomarkers, may allow us then to get to a point where we can identify those who probably do have deployment-related distal lung disease without having to send them for that. And then finally, and again, this is not my data, this is data from Greg Downey's lab. We have gotten dust from joint base Balata and from other areas in Southwest Asia. And Greg's team has moved forward to take a look at what happens to airway epithelial cells that are exposed to Southwest Asia particulate matter. And what you can see here is this dose-dependent cytotoxicity of particulate matter from Iraq related to MLE12 cells. And similarly, he is looking at the dust in the context of particulate matter effects on inflammatory gene expression in these airway epithelial cells. And this is, again, for TNF alpha. You can see there's an effect independent of LPS for IL-6, for IL-1 beta, and then for WISP-1. The Iraq does appear to have a substantial effect in terms of inflammatory inflammatory gene expression in the airway epithelial cells. And they are also exposing both rats and mice in different models to particulate matter from Southwest Asia. And you can see here something that looks very similar to what we saw in the some of the deployer surgical lung biopsies, where there is fibrosis centered around the terminal airways here. So in terms of our future directions, we feel like we've really just started. I think there's a great deal of work that needs to be done to link the exposure data to the health outcomes, to really kind of drill down and understand what exposure risks may drive lung inflammation and bronchiolitis and emphysema in this group. We are developing standardized questionnaires to use in both clinical settings but also in multi-center studies. We have a great interest in the non-invasive markers of lung disease and in better understanding disease pathogenesis, because again, without understanding that, we really don't know what we're doing in terms of treatment. And an important part of this is that, we want to get these folks back and see what happens to them longitudinally. We really don't know what the natural history of this condition is, and whether with removal from exposure or with ongoing exposure, because many of these people want to stay in the military and they cannot stay in the military if they're not deployable, if they're not mission ready. So understanding longitudinally what the risks are and what happens to people is vital. And then, of course, as an occupational medicine person, I always have to say that, prevention is key. That there are substitutes for burn pits, like incinerators, but of course that costs a lot more money than just throwing trash in a large pit and dumping JP8 jet fuel on it. And there are burn pit standards, but that is also often not really mission central. I mean, mission central is, they say, killing bad guys. And, protecting deployers from inhalational exposure risks may take kind of a secondary sort of role in terms of the other risks that people may face. So a whole lot of people have done a whole lot of work and have been really great team members for me. And I want to acknowledge Dr. Silpa Kreft, Dr. Bibi Gottschall, Dr. Richard Meehan, who've really been kind of the key people in our clinical deployment lung group. Matt Strand is a fine biostatistician. Greg Downey is the PI on the GLIDE study. David Lynch, Caleb Richards, and Steve Humphreys are doing the quantitative CT imaging. Steve Grishang really led our histology group. And we have fine people also helping us in clinic. Kaylee Von Felt, Jenny Smith, our physician assistants. Mara Robinson and Jenna Marcotte are our clinical research coordinators. And I want to mention Jane Parr, too. She's here, and I failed to put her name on here, but she has done an enormous amount of work with the histology prep and liaisoning with the USGS people. Bob Miller and his group at Vanderbilt have been vital. And we have had such an interesting collaborative opportunity in working with the geophysicists and the geochemists at the U.S. Geological Survey, with Jeff Plumley leading that team, and Heather Lowers, George Bright, and Todor Todorov really doing most of the actual work. And then, of course, we're very grateful to the military men and women who are helping us out, who are very keen to volunteer and to help their brothers and sisters not get sick. So, thank you.
Cecile, that was great. Let's have some questions from the students and trainees. Go ahead.
So in your data for the 11 people that had the mineral similar ones, do you guys control for like if they were in the same area, like if they were all had the same burn pit exposure? Because it would just be interesting if that would be if that had any kind of cause.
Right. So the comment is that did we control for people being in the same area when we looked at the mineral profiles? And the answer is absolutely not. And that is what is so challenging about this, is that, if somebody's there close to a burn pit, we can describe that, but we're not controlling for it at all. And, there are going to be differences between burn pits. Some are huge. And I showed two different pictures, these big ones, and then this guy kind of just messing with the trash. I mean, a burn pit is not a burn pit is not a burn pit. So, there really is very poor understanding of how to characterize exposure, except based on what they tell us on questionnaire. So it's a great question.
Okay, Julie.
Thank you. I think on that note, I'm interested to know if you think there's a role in epidemiologic studies of civilians living in Southwest Asia and Iraq to see if we can filter out the burn pit effect versus just the dust effect that you're seeing here.
Yeah, that is such an important question, and it's actually a fairly frequently heard question, which is, well, if all this is happening to people who are only there for 12 months or 19 months, what on earth is happening to the people who live there? And the answer is, we don't know. And we have wanted to get more insight into that question, since we started doing this. But it's extremely hard to get that information. And there were conversations within the working group about maybe doing an IRB that would allow us to build a collaboration with local Iraqi scientists to try to understand that kind of background, exposure risk. But it was daunting and really impossible for us to do that. So we would love to know, but we don't have any information.
Along the same lines as Julie's question, have we seen this phenomenon of exertional dyspnea and diminished exercise tolerance in veterans returning from other sort of similar conflicts like the Gulf War or even so far back as like Northern African campaigns?
It's a great question. And the answer is, I don't think it's been, very systematically looked at before. The Gulf War I, the Persian Gulf War, is an interest of Dr. Kraft, who's sitting right down here. And we're particularly interested in the sort of the lung profile from that conflict because of the oil well fires and some of those other things that you've probably heard about. But it never got a whole lot of attention. And the Persian Gulf Wars were also much shorter. Those were 1991 to 92. And so, as we get further and further out, it's harder and harder to, recruit study subjects and really understand what may be going on. So I don't think it's been systematically looked at.
Hi, thank you so much for coming. I'm a resident and I have my primary care clinic over at the VA. And I have actually recently, this last year, had a lot of patients ask me about exposures because they have had pulmonary symptoms. And I don't really know what resources to look at or who to refer them to. Would you recommend that I send them to our pulmonologist at the VA, or one of them even saw immunologists at NJH, and then they recommended having them be seen by occupational health at NJH. But as a provider, I'm just unclear how best to help them.
Yeah, such a caring question. Thank you for that. There are a couple of responses. One is that we're very keen in the occupational medicine program at National Jewish Health to invite people to participate in our research, but also to just come to our clinical evaluation program. And we do take TRICARE, which is how many of these people have come to us, the active duty folks. But now there's VA Choice, and so people, can come to National Jewish Health because we take VA Choice. But excitingly, with Silpa Kraft and York Miller and the folks, Bob Keith and Jack over at the VA, the pulmonary group is making a commitment to understanding this as well. And so there is an interest in having you refer people who have pulmonary symptoms to the pulmonary division, and they will try to help. So that's really just getting started. The other thing I want to say, though, for any of you all who are seeing veterans who are concerned about their health, there is this VA registry. It's the Airborne Registry, an open burn pit registry that veterans can be invited to participate in. And while it's not the most user-friendly instrument, it has a component where if the veteran participates, then their answers can be printed out and provided to their VA caregiver. And so, the veterans can come and provide you with their answers from the registry questionnaire. And that is a way to get started in terms of understanding their concerns. So I would urge people to do the registry too.
Cecile, you haven't told us much about the pathogenesis. You've told us that there's some inflammation there, and maybe these dusts cause an inflammatory response in the lungs of animals. Tell us what the thinking is, at least, in terms of how that inflammation could result in what you're seeing pathologically and clinically.
Yeah, no, that's a great question, David, and I wish I had a good answer to it. You know, I don't. I mean, I don't think we really understand. Although when you hear about people's description of their exposures, you know, it comes as no real surprise that they have airways disease because, you know, they're putting all kinds of things in these burn pits. I mean, you know, plastics and metals and tires and medical waste and you know, dead animals. And so, you know, the complexity of what's being burned in the burn pits is staggering. And a lot of it is a smolder. So, you know, you have fire, but you also have this kind of sustained smolder. And so you have to think that combustion products like, you know, aldehydes and acetoins and the kinds of things that we know, for example, from flavoring workers, can cause distal airways injury are probably part of what people are being exposed to. But, you know, in terms of the pathogenesis, there's very little information. So I don't know.
Question about the incidents.
About, sorry, what?
Incidents, similar to the question about the folks who live in the desert. You've got a tool with that, 2-minute or 2-mile run? You know, they all have to, not all, but those who want to stay in, they have to take it. What % of folks do you think fail the run? I realize it's a crass, crude, but it's something that you have there.
Yeah, well, I don't. I wish I did. But the Army has it. The Department of Defense has information on 2-mile run times. But, you know, and we have asked that question too, because it would seem to be a much larger tool in terms of understanding the epidemiology of exertional shortness of breath if we could look at the change in 2-mile run time before and after deployment. But we have not been able to get access to that data. It's a great idea, though.
So when I was a faculty member at the University of Iowa, I worked with an outstanding lung pathologist who happened to be your father, Earl Rose.
Thanks.
And so I have to ask this question in honor of him and to explain to the students and other individuals that aren't used to dealing with lung disease in the audience. Tell everyone what the difference between respiratory bronchiolitis is and constrictive bronchiolitis and how that differs in terms of prognosis.
Well, respiratory bronchiolitis is felt to be more, you know, sort of a classic outcome of cigarette smoking. And, you know, constrictive bronchiolitis is really a constriction around the lumen of the bronchiole that results in a decrease in diameter. And constrictive bronchiolitis is probably not so much a pathogenic finding of smoking. Respiratory bronchiolitis is, and there tends to be more pigment around respiratory bronchiolitis and, you know, less around constrictive bronchiolitis. So, you know, most people think of RB as a smoking-related effect on the distal airway, and constrictive bronchiolitis is more something that tends to be related to exposures. So classically in occupational medicine, exposures to sulfur dioxides or nitrogen dioxides can cause constrictive bronchiolitis, or more recently to diacetyl and other flavoring chemicals that appear to, again, injure the distal airway and cause this injury and constriction and fibrosis around the airway rather than just, you know, a kind of particle deposition, which is more typical for respiratory bronchiolitis. I don't know if that, I mean, I was going to ask Ruben to answer that question, but he left.
And constrictive bronchiolitis can oftentimes lead to lung transplantation, result in lung transplantation as a result of really extensive injury to the very distal portion of the lung that prevents the alveoli from fully oxygenating and exchanging carbon dioxide. So there was,
transplant.
Without good treatment. Yeah.
Yep. Yeah. And you can get an obliterative bronchiolitis, for example, after lung transplant as a kind of a graft versus host sort of effect, too.
Other questions? Cecile, that was great. Thank you very much.
Thank you. Can I say one more thing? I just want to make a shameless plug for you all to think about doing more in occupational environmental medicine. It is such an interesting, such a fascinating area of medicine, and it is one that I believe you get very little sort of face time with. And I want to end by saying that probably most of you do not know, but Dr. Schwartz is board certified in occupational environmental medicine, and he figured it out, and we think he's doing pretty well in our field. So I just would like to urge you all to think about, coming to our clinics, participating, exploring how you might get involved with this. So it is really the most interesting work you'll ever do. Thanks so much.
Thank you. And next week we'll be back in the Schruffel Auditorium. Thanks again. Bye-bye.
Thanks. Good to see you.
Say that once again.
For disability, because they'll be disabled.
Yeah, you do.
Do what
Yeah.
they did.
You
So
do.
does National Jewish do it?
We do.
Yeah.
Yeah, we
National
do
Jewish
disability
says a
evaluation.
lot of places do it, but they do it much more consistently and in a uniform way.
Do we do it in the university?
I'm sure that it does exist. I don't even
Okay.
But I am a university.
You are the university.
Well, I mean, I'm not National Jewish, but I can say, I value
So
my
do you
academic
do like
appointment. I have colleagues who do. I don't. I'm not good at anything but the one.
You'll be seeing a lot of my patients.